Good morning and welcome to this meeting of the Health and Wellbeing Board. I am Gordon Oliver, the clerk for today's meeting, and I'm supported by Vicky Phoenix as a Zoom host. Before we start, I'd like to explain for the benefit of the members of the public who may be watching that today's meeting is being held in a hybrid format. We have a quorum of board members in the council chamber with other board members attending remotely. The meeting's been live streamed via YouTube, so members of the public are able to follow proceedings. There are no fire drills planned today, so in the event of a fire alarm, we must leave the building immediately via the emergency exits. The assembly point is the Dolphin Pub car park. If the lockdown alarm sounds, we will remain seated and await instructions, and we'll adjourn the meeting until such time as it's safe to proceed. Do members have any questions about the way in which the meeting will be conducted? No, thank you. So the first item of business on today's agenda is to elect a chairman of the Health and Wellbeing Board for the 2024-2025 municipal year. Are there any nominations for chairman? Councillor Foot.
Thank you very much. I'd like to nominate Councillor Heather Codling, please.
And does that find a seconder? Thank you, Matt Pearce. Are there any further nominations for chairman? No, thank you. For those members of the Health and Wellbeing Board present in the council chamber, all those in favour of electing Councillor Heather Codling as chairman, please raise your hand. And anyone against? Any abstentions? No, thank you. I can declare that Councillor Heather Codling is elected as chairman for the 2024-2025 municipal year.
Thank you very much, Gordon, and thank you very much, everybody, for electing me as chair. It's a very long time since I chaired a meeting in this room. It's about 30 years ago, so please bear with me. I'm out of practice. And it wasn't a health and wellbeing board, it was a planning meeting, so a long time ago. So, and I'd like to minute the contribution that Alan Macro gave in chairing this meeting previously. So if we could do that, thank you. Then the next item then is to elect a vice chairman for the Health and Wellbeing Board for this year, 24-25. And from the chair, I'd like to nominate Sarah Webster. Does that find a seconder? Thank you.
Yes, Chair, I'd like to second that. Thank you very much.
Are there any other nominations for vice chair? I know she's not in the room, but she is aware that she's being nominated. We're not doing it behind her back. So, okay. If everybody's happy then, so can we have a show of hands for Sarah, please? Any against or abstentions? No. Thank you. So I can declare that Sarah Webster is elected as vice chairman for the 24-25 municipal year. So do we have any apologies?
Yes, Chairman, we have received apologies from Paul Coe, Anne-Marie Dodds, Matt Hensby and Sarah Webster.
Thank you very much. So before I move on to the minutes, I just want to welcome Matt, who I understand has worked here before. We've only met for the first time, so, and also to thank John for coming in person today, because I believe this is your last meeting with us. So. Excellent. Well, thank you too for your contribution. It's been. Thank you. So, right. So if we go on to the minutes, has anybody spotted anything they want to change or anything they've noted before we seek approval? Yeah. Rachel.
Good morning, thank you, Chair. It was just a correction on item 80, please. It's a volunteer centre and it references the fact that we do mental health first aid training, which at the moment we don't actually do.
Sorry, item 80 on this minutes I've got here references suicide prevention. Am I looking at the wrong bit? Sorry.
No, I think you're looking at the right bit. Bear with me as I flip through. Where have they gone? It talks about, yes, so that it's a reference to suicide prevention and mental health first aid training. We only deliver the suicide prevention training. We don't deliver the mental health first aid training.
Beg your pardon. Thank you. Yeah.
Okay.
Thank you very much. If we can correct that. So Okay. Can I have a proposer to approve the minutes, please? Nigel?
Happy to propose, Chair.
Thank you very much. And a seconder? Thank you, David. So can we have all those in favour, please? Yep. Those minutes are approved. Thank you very much. Do I actually physically sign them? At the back, right. So some things still remain on paper then. What are we there? 11. Thank you. Right, so if we can go through any actions arising on the minutes. So the actions arising, and I'm just trying to find the right ones. The annual report has been added to the forward plan. Zoe, going on to item 80, the suicide prevention strategy, Zoe was going to confirm if that SPAG had been consulted. April, can you update us on that? Do you know?
I do believe that they had, but I will need to double check with Zoe that is the case. Gordon, I don't know whether Zoe's confirmed to you regarding that.
I can't recall. I need to check.
Chair, and come back to you on that.
Thank you very much. And then April, the next item you were going to consider, April, about how rural issues could be addressed. Is that a longer term thing?
It is, and we've had a discussion and think that a hot focus session coming forward soon would be a really good way of addressing that, if the board is in agreement.
Thank you, that sounds sensible. And then the next one was the strategy action plan, and that would be coming forward to another meeting. I'm just going through. Then on to 82, the cost of living crisis. Sean and John were going to discuss how the public health team could be involved. Will you bring that to when it's under the agenda item?
Yes, Chair.
Thank you. And then the other thing is the health and wellbeing dashboard and the numbers, and actually showing the data sources so that they were more in line with the years was the other thing we wanted on there. I don't think there's a couple of other actions, but I don't think there's anything that needs mentioning. Okay. Right, so if everybody's happy, we'll move on. Do any members of the board have any declarations of interest? No, nothing. Gordon, do we have any public questions?
No, Chairman, we've had no public questions.
Okay. And do we have any petitions that have been submitted?
No petitions received, Chairman.
Thank you very much. Right, so we now move on to the membership of the Health and Wellbeing Board. As you know, this is a standing item, and the members are on an organisational basis, which allows for change in personnel. And we've had a couple of changes. So councillors Patrick Clark and Nigel Foote have replaced Alan McCrow and Janine Lewis. Matt Pearce is the new Director of Public Health, and Stephen Bow is the new consultant in public health and will be Matt's substitute. And as I've already said, this is John's last meeting. And Bernie Prizeman has been nominated as Rachel Peters' substitute. So if everybody's happy with that, we'll move on to the next thing, which is item 10, the annual public health report. John, can I hand over to you for this?
Yes. So it's a great pleasure to present this. You've got the slideshow there, Gordon. This is the first time there's been a specific public health annual report for West Berkshire. And so in producing this, There seems to be conclusion and priorities is up on the. Okay. What I've done, what the team have helped me with, is to set the whole context about how public health essentially has come home to local government after a very long journey that actually began almost 200 years ago in local government. And that what I've rehearsed in here is where it's been over the different years and how it's changed and what the scope is now. So the report structure, I've got about 20 slides here, but I won't use them all. But I encourage you to give it some attention when you've got time. It's on digitally and will be on a public access site, and I'm hoping there'll be some hard copies for those who would like hard copies as well. So it sets the scene. It's about public health coming home. It's a vision for West Berkshire. We've rehearsed through the different domains of public health. We talk in public health about health protection, about health improvement, and about population healthcare as the main strands of public health activity. Setting the scene, yeah. So it's an opportunity to take stock. The history of these reports, which is, as I say, goes back a long way, was that they were seen as being the independent report of in the old days, the medical officer of health, but now the director of public health, that were in a sense similar to the auditor's report, that they were holding up the mirror to the council, that the officer could draw attention to things that were of concern, even if they might not be popular to do so, and that these reports were presented at the annual general meeting of the full council with the press present. The tradition also in the previous regimes before 1974, when there was major local government reorganisation, was that the medical officer of health then could not be sacked for saying unpopular things, only for incompetence, and that was to make sure that there was this sort of external perspective. So in this report, we really emphasise how prevention is the key. On a number of places in the report, attention is drawn to the major challenge that we face with the demographics and the changing expectations. This is particularly pertinent with the discussions that's going on at the moment about the rebuild of the Royal Berkshire Hospital and what kind of healthcare system is needed for an ageing population and a rapidly growing population, and the major challenge of transforming the healthcare system into one that's based on public health, primary and social care, and supports self-care of people in their own homes. Let's say the social goal here of the 21st century is to die young, as old as possible. This is about keeping people fit for as long as possible. So this slide just has a few bullet points about where we've been on the journey. It's interesting, picking up that second point, that at a time when there's such a lot of concern about the physical state of the population, obesity levels of 60% of adults and so on, that back in the early years of the 1900s, when the country was at war in South Africa, a third of working class recruits were unfit for military service. And in 1906, there was a major report on the physical condition of the population, which led to a whole series of measures, which are described in the report, which included school medical service, school medical exams, school meals, milk in schools, and other kinds of measures. that are to be identified there. In many ways, we've gone backwards since then, and we're at the moment trying to put some of these things back together again. Humpty Dumpty fell off the wall, and we're trying to put him back on as we go forward now. Just a flavour of some of the old reports. The quoted in this report is the 1852 report of the sanitary inspector for Newbury, William Lee, who illustrated the living conditions, reported sanitary problems, sewage problems, drainage issues, lack of drinking water, overcrowding, flooding. Sounds very similar to today. It also highlighted the excessive high mortality rates from preventable diseases. And it really is salutary to look at this again. It highlighted that the health of the town could be improved through actions of the local authority, of the town council and improvement commissioners. A later example of these reports was the Berkshire County Council Public Health Report in 1923, when Gerald Taylor, who was the County Medical Officer of Health, revealed significant advances in population health, attributed to the effectiveness of public health interventions, including on sanitation and socioeconomic conditions. He talked about how the population had increased and there'd been a decline in infant mortality and migration, and other things that are there, which I think you'll find interesting reading. And as I say, it resonates with the picture we paint today of what we have to do. We go on to the public health vision. Yeah. So we're talking about population level interventions, taking a place and asset-based approach to working with communities, doing things with the public, not to them, and maintaining a relentless focus on reducing health inequalities through partnership working and high quality public health services. The public health grant, which the Director of Public Health has oversight of, is to commission particular public health services. It's not big for West Berkshire. It's £5 million or so a year. It falls into insignificance compared to a big authority such as the one I'm most familiar with, which is Liverpool, which has a budget of £45 million. And so one of the challenges for Public Health Director and for Matt going forward is how to get the most out of that budget, how to optimise the capacity, turn to a situation where the whole of the council is effectively a public health organisation, and that everything that the council does really is looked at through the lens of health protection and health improvement. And the jargon that's used for that these days is health in all policies. So just some highlights. Newbury is, and West Berkshire is obviously a fortunate place to live and to be, but that doesn't mean it hasn't got its problems. There is high vaccination coverage, but there is local variation, and there are some pockets of poor vaccination coverage. We've been doing some work to focus in on neighbourhoods and schools where that's the case, to see where action needs to be taken. There are apparently low levels of sexually transmitted infection and HIV diagnosis, but hiding behind those numbers is the suggestion that actually access to those services may not be very good, and we may not be actually reaching all the people in need. Smoking and alcohol misuse rates are in line with England, but inequalities persist. We've achieved a lot. We continue to achieve a lot through the vaccination efforts addressed particularly at the more vulnerable and aging populations, and the programs that are in place to continue to chip away at smoking levels and so on. Nationally, adult smoking levels these days are around 10 or 12% of the adult population, and that's similar here. But in Wokingham, adjacent, it's down to 5%. So you know, there's more to be done, and in some population groups and areas, the smoking levels are still quite a lot higher than that. So there's work to be done there. So going forward on health protection, it's necessary to continue to strengthen the arrangements. We've been building on the arrangements that were put in place during the pandemic. We've been moving forward on establishing a joint approach across Berkshire with the other local authorities and with the Health Security Agency. But these days, we think of a bigger canvas for health protection than was the case historically. Historically, it was largely to do with infectious disease. Nowadays, we think about external threats to health, which can include environmental, chemical, biological. Here we've got nuclear nearby. So there are quite a lot of external threats to health, and also such issues as commercial determinants of health, noxious influences such as gambling promotion, the impact of social media on young people, and violence as a public health issue. So there's a big agenda for health protection. So I think if we go on to health improvement, Gordon, please. So looking at child health, there are more attendances of under fives at A&E compared to England, and higher rates of tooth decay. There's obesity, as mentioned before, which you know, tackling this requires a whole system approach, because we live in a obesogenic environment, which actually encourages people to eat the wrong things. And it's not just a question about individual choice, it's about the environment in which those choices are shaped. Again, the World Health Organization has an expression which is to make the healthy choices the easy choices. And that's what we must strive to do. Adult health, I mentioned already, obesity levels, and the three highest long-term conditions are depression, hypertension, and diabetes. There's good work going on in each of those, but we've got to scale it up, and really there's more that could be done. Mortality from preventable cancer, cardiovascular disease, and respiratory disease is lower than national average, but we still saw over 100 deaths that potentially were preventable in West Berkshire in 2021. And that's where public health, working with the National Health Service, working with GPs, working with hospitals, ensuring early access to interventions, and that's equitably the case is really important. So on the next slide, the health improvement, what we've achieved. Oh, where is that? Sorry, don't worry. There's quite a few slides here. Have you lost it, Gordon?
Apologies, I think this may be the old version of the presentation.
Yeah, maybe I've got different. Don't worry about it. Sorry. So extensive health improvement programs of work are in place for children and young people with public health nursing, working with the development of family hubs, Flying Start, parenting and family courses, every child a talker. Literacy is still an issue. It's very important, particularly with new citizens from abroad. Healthy weights, smoking cessation, mental health promotion. There's a whole range of things which we're doing and which we need to develop. Moving on to healthcare, public health. So we've collaborated with the Integrated Care Board to fund a community wellness outreach service aimed at identifying those at high risk of cardiovascular disease and improving access to NHS health checks. You've heard that you now have a new director of public health, Matt, who's taken up the reins recently, and a new consultant. So we'll be in a position for the public health team to be built up, and externally commissioned public health services are in place. So what needs to happen now is to provide strong, visible public health leadership. The bookends of public health are intelligence at one end and communications at the other. Analysing what the issues are, understanding those in fine detail, drilling right down to neighbourhood level, seeing where the differences are between different populations and groups, seeing where it's best to intervene. So public health intelligence has always been the foundation of public health action, and ensuring that the intelligence is well integrated into the corporate intelligence of the council on the one hand, but also that the intelligence is carried out collaboratively with the other local authorities and with the NHS. It's a big task, that, and I think we're in the foothills here. There needs to be more investment in intelligence. There needs to be more development in intelligence. At the other end, communication, taking the public on a journey. It's not just public behaviour that has to change. It's the behaviour of commercial companies, of organisations, of all sorts. So there's really a major task of communicating what this agenda is, what needs to be done, where the best interventions are, and hopefully this first dedicated annual report for West Berkshire will provide the basis for that action going forward, and I'm sure that Matt will be more than capable of doing that, together with everybody else, of course. I just touch on a couple of things, but I won't show the rest of the slides. So we're looking at how you develop the public health workforce, what the arrangements are for appropriate research, what the linkages are to Reading University and other academic centres, evaluating what we do, and really ensuring that people appreciate that public health is not just a matter for people with public health in their job title, but it's actually something which it affects all aspects of council business. And how do we make that explicit? So a balanced approach to improving public health across three populations: the whole population of West Berkshire, the populations of people who are at risk for particular conditions and issues, and the third set of populations are those who've got specific established health problems, and how do we ensure that they have equitable access to the right kind of care to enable them to continue to live a full life as far as possible, even though they may have long-term conditions. So this is the agenda. All of this evidence-based. So again, must be 10 o'clock. Okay, so that's all from me, really. I'd just like to say, you know, because this is my sort of swan song, really, how much I've appreciated working with Paul Coe and the others, and the support I've had from the council. And if there's time for questions, I'll happily try to field them. Otherwise, I'll leave them for Matt to pick up once I've left.
Sorry, does anybody want to make any comments about that?
Thank you. I just want to say thank you to John. It's always very interesting to hear you speak with your vast amount of experience and knowledge. And the report is extremely interesting. It is probably one that I need to go back to again because there's a lot of detail in there. And there will be moments, I'm sure, throughout the coming year where we need to refer back and just sort of double check ourselves. And it will be a great basis for Matt to start from. I just wanted to highlight one of the things that you mentioned, and you talked about social media, which is one of those areas that is a blessing and a curse, as we all know, in many situations, and how we protect our young people in particular, but also other vulnerable groups. And I'm thinking it's something that I saw last night where you're watching the football and you think, gosh, this is amazing. And suddenly something pops up on your social media to tell you that you can get an amazing deal on pizza if you want to watch the match on Sunday and things like that. Clearly pizza, I'm just picking that as an example. If you eat it every day, lucky you. But actually, you know, the choices that we give people, I think are very, it makes it quite difficult for them to make a good choice. And in particular, when we're talking later about whether we're still calling it the cost of living crisis, but the current situation that a lot of our residents find themselves in financially, those decisions are very difficult to make if actually you have a very small purse of money to work with. And seeing something like here's a deal and I can feed the family, then, you know, that's a choice you have to make. So there wasn't really a question in there. I apologise. It was a bit of a...
Well, I'll give you an answer.
Oh, that's lovely. Thank you.
No, I think we're in the foothills of it. And as you say, it's a plus and a minus, social media. Yeah, I was working for a time during the pandemic with the Kingdom of Bahrain with the pandemic task force, and they very sophisticated use of social media in the pandemic. 80% of adults in Bahrain have an iPhone, and they were getting messages every day on their iPhones about what to do about the pandemic. It's very, we barely scratched the surface of that kind of thing. In Reading, we've now retained the services of a local PR company, communications company, to do the public health messaging and they're called Blue Lozenge. I know Matt's already got interested in what they've got to offer. And they are segmenting the market with social media to target particular areas and groups and so on with particular messages, and they're able to monitor the pickup of the messages and the hits on the internet. So there's a huge amount of potential for this as we go forward, but it requires investment.
Nigel.
Yeah, thanks very much, Chair. John, could I also thank you for that presentation. I personally love the historical connection because you get a sense that what goes around comes around. And sadly, we seem to be heading back in many indices to that 1900s event. And you mentioned the South African War. I believe I'm right in saying the Royal Army Dental Corps began as a result of the poor dental health of the recruits. Again, it was realized that they couldn't even eat their rations because their teeth were so bad. So that triggered that situation. And of course, we're in a climate now where dental provision is at crisis level, to be honest. And that's a whole other aspect, really. But what I wanted to ask you was, before you leave us, if you can use your experience and give us an indication of how in public health, with essentially the preventative measure, and you've mentioned health in all policies, which is, a fabulous concept, how we can, as a nation, fund that. Because if we can do that properly, surely we're going to save a lot of money at the sharp end, i.e. the NHS, of acute care provision. And it seems to me that there are two massive silos and that, funding into public health doesn't necessarily get truly reflected in the savings that could be made in acute medicine in the NHS. Now, I realise that's a global question for the whole country, but could you give us your take on that situation?
Yeah, I'll try and keep it brief. I mean, I could talk about this for a long time. Just on the dental one first, though, you know, prevention is invisible. This is part of the problem. I mean, you may have heard me tell the story before about the two men on a train in Africa, and one of them's throwing powder out of the window. And the other one says to him, "What are you doing?" He said, "I'm throwing powder out of the window to keep the elephants away." And the other one says, "But there's no elephants." And the other one just says to him, "Well, you see, it works." And making prevention visible is a real task. I mean, I'm old enough to have grown up in the 50s, you know, revealing, sorry. And there were still a couple of kids at school who had polio, and there were other, you know, things that were still around. When it comes to dental health, poor dental health was associated with rheumatic heart disease, which has long since disappeared, but it could come back. We've got people pulling their own teeth out. You know, so you can't afford to take your eye off the ball. The NHS has been a wonderful innovation, but the paradox was that when the NHS started, it coincided with the disappearance of a lot of the infectious diseases, partly because of improved living and working conditions and standards of living, better nutrition as well, and smaller family size, because you didn't have these big families of 10 kids competing for scarce food and so on. You know, small families meant better nourished children, and vaccinations as well. But we threw the baby out with the bathwater after 1948. General practice was neglected. Public health went into a decline. When I came into public health in the mid-70s, you know, only failures went into public health, or people who had some kind of mad mission to change the world. You know, I hope I was in the latter group. And so we threw the baby out with the bathwater, and we've been over-dominated by a belief that pharmaceuticals were going to bail us out on everything. Now, what the Victorians did was what I would call horizontal interventions rather than vertical interventions. So by putting in safe water, they dealt with a number of different diseases. So it was one thing having safe water supply, domestic water supply, got rid of cholera and typhoid and, you know, a range of infectious diseases from one measure. So the question really today is, what's the horizontal measure? Instead of having a program for heart disease, a program for cancer, a program for, you know, sexual health, what are the horizontal things that will actually pick off many different things? And so when you look at where we tend to get stuck in behavior change of individuals, you know, drugs and sex and rock and roll and sport and obesity and so on, what's the upstream determinant of the determinant of all of that lot? And I would argue it's the extent to which individuals are in control of their lives. So there are measures that can be that you can use to assess populations about locus of control, sense of coherence, internal versus external directedness. Because if you're your own person and you feel a mastery over your universe, then you tend to live a healthy life. So, you know, that's all comes down to how do we give a good start in life in the early years? How do we support, firstly, planned parenthood, having children born into an environment that's nurturing, not having children born into an environment which is a disaster from the start. So planned parenthood, parenting support, ensuring school readiness, which is in the public health data set, preventing school exclusions. because once kids get excluded from school, they get into all sorts of trouble. And ensuring that young people are ready for the world of work and for adult life at 18. When I was working in Cumbria, I had this mission to say, what we need, there's 5,000 births in Cumbria every year, 5,000 school leavers. We need 5,000 passions. You know, each person needs a passion in life by the time they're 18 that's not going to get them into trouble, and it'll stay with them, you know, throughout their adult life. You know, so these are the sorts of things that we really need to be addressing. I think they would be horizontal approaches.
Thank you very much, John. I actually want to just comment about that as portfolio holder for children services. Certainly looking after children from pre-birth to when they're 18 or 25 if it's an SEN situation. We have to have them ready for school transitions and all that sort of thing. And that is critical to what we do with those young people, to their results and how they approach life after that. Absolutely. The other comment I wanted to make, which follows on from the pizza comment, I'm not a fan of pizza, so, you know, I'm safe from that one. But obesity seems to be a big link. You said illnesses that seem to cause huge problems, depression, hypertension and diabetes. Well, a lot of that will link back to obesity, and the numbers you've quoted for young people being obese is quite scary. So, you know, those are pieces of work we need to do, and perhaps, you know, that's another hot focus session as to how we can deal with that. So
and you don't deal with it by hitting people over the head about it. You have to come at it in a whole system way to make it easier for people. I mean, I was in Spain just a week or two ago for a short break, and you see far fewer obese people in Spain than here. You come back here and you're coming through the airport, and you can't move for obese people, you know.
Yeah, unfortunately that is, yeah. So does anybody else have any other comments before we move on? So, Sean.
Thank you, Chair. Thank you for the report, John. I just really wanted to pick up on the point about health in all policies, and I do think that's absolutely key to what we do. I mean, we recently had a hot focus group on housing, and I think some of the people in this room were at that meeting. And what's clear is that the cost of dealing with the symptoms is far more than dealing with the causes. And it's how we draw that line, basically, to almost have a fundamental reset, basically to deal with some of the causes and some of the preventative actions that we could actually take. I mean, housing standards is an absolute classic example of that. You know, poor housing, there are very clear links between poor housing standards and poor health. You know, and when you've got situations such as, you know, overcrowding and damp and cold and mold, and all of those issues, basically, the impact on health can be significant. And yet, actually, the interventions to deal with that early on are relatively cheap compared to that. And I do think we need as an organisation, as a group of organisations, and there are lots of people who have a part to play in this. It's not just the council; it's lots of other associated organisations, the voluntary sector, and everything else. All basically, a lot of the time, are dealing with the symptoms. I'm very, very keen as we go forward, and we'll perhaps pick this up on the paper later on, that we really need to move to a situation where we have some idea of what are acceptable living standards, basically for people in the borough district.
So, I mean, again, I don't want to, you know, take up too much time. I mean, I could talk about that issue for a long time. Many people don't realise that when the National Health Service was set up in 1948, the first Secretary of State for Health was the Secretary of State for Health and Housing. We really understood the linkages at that time. Since then, they've diverged. In the Victorian period, public health and town planning were Siamese twins. It was about designing out you know, industrial and zoning, having industrial areas, residential areas, recreation areas in towns, and public health and town planning worked absolutely hand in glove. We lost all of that in the last 30, 40, 50 years. Because if we're talking about designing places for people to live in, this is not the same as the mindset, which sees houses as being about bricks and mortar and numbers of units. I mean, I used to be on the board of Liverpool Housing Trust, which is one of the big housing associations, and I've got a long-standing interest in this whole area. But builders are not on the case, and we've got to really, as you were suggesting, up the ante. One of the things we did in Kendal when I was working in Cumbria was to get all the people involved in housing together for a day, the private builders, the housing associations, everybody, to really start a conversation about what needs to happen going forwards. To give you a couple of examples, we know from the work of the old age person czar, a doctor that was appointed during the Blair years, that if people who've got dementia are in the right kind of housing, and there's a whole literature on that now, they can stay independent living in the community where they've been for an extra 1 or 2 years. Now, up in Cumbria, I did it all on the back of an envelope. We had 5,000 or 6,000 people with dementia, heading towards 10,000 people with dementia, because a lot of people retire up there and all the rest of it. If you've got 10,000 people who are able to stay in their own home for an extra year or two, that is 10 to 20,000 bed days not needed in care homes or in hospitals. But it means you've got to design the housing to be the right sort of housing, and the neighborhood. It's not just the housing, it's the neighborhood, it's the configuration of open space, it's the safety aspects of all of that. What we learned from the pandemic was that a lot of people are living in accommodation which is totally unsuitable for a pandemic. People who didn't even have a balcony to sit out on and get fresh air. That if you had somebody who was infected, then the bathrooms and the sanitary arrangements weren't adequate to keep the other people safe in the house. You know, we haven't had the conversations about what a 21st century housing standards looks like, not just bricks and mortar, but socially, psychologically, and so on. I remember when I was a GP having a couple I was seeing a couple, I can't remember why, but they'd stopped having sex because the walls were so thin that their teenage kids could hear them having sex. So they stopped having sex. You know, that's part of life, quality life, is actually having a house where everybody can live their lives out the way they're supposed to be lived out, you know.
Nigel, you wanted to come back.
Yeah, just very, very quickly. You mentioned, John, about link up with research, and you mentioned Reading University and things. And one of the things that's interested me is ways of measuring preventative input. You know, your lovely story about the chap throwing the paper out of the train. In your experience, are there circumstances now, and are the academics looking at ways of measuring a preventative intervention so that we can quantify that in monetary terms? Thanks.
The short answer is yes, but you have to find them. You're fortunate because Matt's got good academic links, and I'm sure he'll be working on how you develop them. You see, the discipline of health economics isn't really health economics largely. It's mostly health service economics. Proper health economics would be looking at, if you're investing in housing, or you're investing in recreation, or investing in some other area, what is the health gain from that at a population level? What health economics is largely about is if you spend money on one area of medical practice rather than another area of medical practice, it's about marginal benefit, you know. And health economists aren't to be found easily. I think there may be some at Reading, I'm not sure. The big health economics outfits are Aberdeen, York, and Aberystwyth, Bangor, not Aberystwyth. But there is health economics around. So that's one of the things you need. But you really need to cast your net on the waters to find the right kind of disciplines, because you need, well, I'll give you another example. When I was in Cumbria, we funded a youth zone in Carlisle. A youth zone, there's several of these. I'd encourage you to think about youth zones. The first modern one was Bolton. The Bolton Lads and Girls Club, which was a Victorian thing. Some visionary in Bolton about 20 years ago came up with this idea about having a modern youth centre, and they got a load of lottery money for the bricks and mortar, and then they made it into the hub and spoke for youth facilities for all the young people of Bolton. There are several of these in the northwest now, but we did one in Carlisle, and I put public health grant into it, along with the police put money in, the education sector put money in. There's about 5 or 6 of us who put money into this. There were questions asked in the House of Lords about why public health was spending money on a youth club at the time, but we did it. And the evaluation is a basket of indicators about educational attainment, teenage pregnancy, involvement in criminal justice, and so on. So we commissioned an outfit from, I think it was Central Lancashire University, to do the evaluation on that, you see. So you have to find, it's horses for courses, you have to find the people, but you're talking about multidisciplinary interventions, and they require multidisciplinary evaluations. Yeah.
Thank you very much, everybody. So thank you very much. This is an item to note, so we don't need a vote on it.
Thank you.
So we'll move on to item 11, which is the changes to pharmaceutical services. April, if I... Oh. I've got that down. Yeah, sorry, you're right. I'm looking at the wrong one. Annual report, sorry, item 11, annual report. April, they're both you anyway. Thank you.
Thank you, Chair. So hopefully you've all had a chance to look at the Health and Wellbeing annual report that was included in the pack. So to say that this is the first annual Health and Wellbeing Board report. And to start with, I would just like to give my thanks to Gordon Oliver and Zoe Campbell for all the work that they did with our partners in the board and with the subgroups to help put this first report together. So I think it is a really good report, and we've tried to focus on the work that's been carried out over the year on our 5 health and wellbeing priorities. So we just have provided quite a neat synopsis of some of the key activities. Obviously, there's a lot more work that has been done, but we've tried to really focus in on those things that we felt really achieved the priorities. So it's really just to say that the report will be on the Health and Wellbeing page of our council website. So that's where it will be. So our residents will be able to have a look at the report, and so will our partners. And just to really seek any comments in regard to the report from the board.
Does anybody have anything they want to ask or say? Jo.
I can't let April go without saying something about her report. I think it looks really good in terms of it's really easy to read. And I think that's really important if we want not just this board to read the report, but our residents. And anything that is long and complicated is likely to be, you might get through a few pages and then stop. So I just want to say I really like this format. I will say I haven't got right to the end of it, so I apologise. I think it came a little later than the rest of the pack. But I'm really impressed with it, and I think if we have a similar format moving forward, I think it will be very, very useful.
Thank you, Joe. Yes, I would agree. It's easy to read and it's visually quite draws you in. Matt, I think you wanted to comment.
Yeah, thank you. Like to echo that. And firstly, it's great to be back in Berkshire and really looking forward to working with you all. Having been involved in the development of the strategy several years ago, it's really nice to see this, I think, in that format. It clearly shows April and others, there's a great work that's being done. Agree, the format looks fantastic. I particularly like the journey so far. I think it just shows the complexity that we're operating in, whether it's within the NHS, the voluntary sector, and the council. I guess my only point really is how we can, and I think there's some reference to the indicators that we're trying to improve. So some of the things that John made reference to, and I think this may have been a topic at the board before in terms of actually what are the outcomes we're changing. Whether it's childhood obesity, whether it's oral health. So there are some reference in that, and I appreciate that's completely challenging given what John has alluded to today. But overall, I think it's a fantastic report. I'm really looking forward to driving the Health and Wellbeing Board strategy forward with partners over the coming years. Thank you.
Thank you very much. So thank you, April. Oh, you have another comment?
Just very quickly, thank you, Matt, for your comments, and also thank you to Councillor Stewart for her comments too. So, Matt, just to say that there is a dashboard that we have been developing, which will help complement our work to make sure that we are measuring our outcomes. That still is very much work in progress, and would really appreciate your input on that dashboard going forward to get it as good as we can. And as effective we can to make sure that we are measuring as much as we can in terms of those outcomes. So thank you both.
Thank you very much. Nigel.
Yeah, thanks very much, Heather. Yeah, could I ask, April, with the fact that this is the first annual report, and again, I would echo what colleagues have said about the fact that it's easy to read and the infographics are really good as well. And bearing in mind this is going to be a public document, is there a plan afoot to have a sort of short summary of what our objectives are each year, and just almost a small table so that members of the public can refer to that and see our progress on that in a very simple format? Thanks.
Thank you, Councillor. But so at the end of the report, we did do a very brief summary in terms of what are our objectives going forward for the next year. But I think you make a good point, and perhaps as part of when we put this plan onto the webpage, we could put something similar to say what our objectives are for the next year. I think it's a really good idea. Thank you.
Thank you very much, everybody. If there are no further comments, then we actually need to agree this annual report. For present, it has to go to council by the look of it, so for acceptance. So if I could have a proposer for this report, please, Nigel, and a seconder. Joe, thank you. So all those in favour, please. Any against or abstentions? No, thank you. Thank you very much. Thank you, April. So we will go to the next item, 12, changes to pharmaceutical services, and back to you again. Thank you.
Thank you, Chair. So this report provides details of proposed changes to pharmaceutical services in West Berkshire and advises the Health and Wellbeing Board on the implications for the West Berkshire pharmaceutical needs assessment. The West Berkshire Health and Wellbeing Board has a duty to keep its pharmaceutical needs assessment under review in light of any notifications and changes of pharmaceutical services within the district. Notification has been received for an application for inclusion in a pharmaceutical list at Kingfisher Court, Newbury, in respect of distance selling premises by Halo Pharmacy. The application for distance selling will serve the whole country and will not be seeing anybody face to face. So therefore, it is considered that there are no implications for residents or for local pharmacies. Just to say that a previous application was submitted by Halo Pharmacy Limited, and the board agreed a response prepared by the Director of Public Health in consultation with the Chairman of the Health and Wellbeing Board to confirm that the board had no objections to that proposal. Given that the board has already responded to the previous application, it is not considered necessary to make a response in relation to the new application. So as a final comment, the Health and Wellbeing Board is asked to note the application for inclusion in a pharmaceutical list at Kingfisher Court, Newbury, in respect of distance selling premises by Halo Pharmacy Limited.
Thank you very much. Does anybody have any comments at all? John?
These issues about pharmacy openings and closings and so on are all very well. And I mean, some of my colleagues, they ask why on earth public health are getting involved with this and so on. And I think there's something about the framing of pharmacy and its contribution to public health, which isn't being addressed. I think we might have touched on this here before. When Frank Dobson was Secretary of State for Health, he said he was shocked to discover that pharmacists spent 5 years training to be pharmacists and then they worked as shop assistants. There's something about the skill set that's represented by the pharmacy. So we've now got this new initiative from the previous government on Pharmacy First, which is about extending the range of things that might be available in a pharmacy, and some consultation, some prescribing and so on. But I don't think we've really stood back from it and said, what's the actual role of people who've spent 5 years training in medicines and drugs and things as part of the team, the bigger team. And so one example I thought of was, maybe pharmacists would be the ones to go into talk at schools about the drugs that children are taking, young people are taking, street drugs and things like that, because they know about toxicology, they know about the medicine. Is there work they could be doing which is more of a population type rather than an individual customer type? And where you have pharmacies within health centres, again, I'm familiar with some of that in the more rural parts of the Northwest, then they get involved with medicines management, which is an issue. I mean, when you get to later life, you might find yourself on 10 or 12 different things, and you don't know who's keeping an eye on that, who's scanning this and all the rest of it. So I just think that there's some development work to be done of saying, what would the vision be of the role of pharmacy in public health, which goes beyond these kind of issues that get brought here about opening and closing pharmacy.
Thank you. I can come in.
John, completely agree with that, and I'm pleased to say that. I believe we're already starting to make headway on this, in that our community pharmacy is now part of the extended family in primary care, and I'm sure Helen can help speak to this a little more. And hypertension case finding, as you know, is something that they've been working on already for at least the past year and a half, 2 years. Across Bob, we've got some 253 pharmacies that have signed up to this. We've done over 26,000 hypertension opportunistic blood pressure checks. And our community pharmacies can give advice on how to use your inhaler. I certainly make use of that a lot. So from the time that we might show the patient how to use the inhaler within the primary care practice to the time that they pick up the instrument or the device, a lot can go missing, and our community pharmacy can actually show how to use the new medications that have been started. They actually can advise, and they do a review of the patient a couple of weeks, if not a month later, to see how you're getting on. These are some common side effects. And another really important thing that I believe is that better relationship between your local community pharmacy, so the ones that are open and providing face-to-face consultation, and their local GP practice. And that is something that we are actively working on improving that. Yet again, to go back to the hypertension case finding, we know that the community pharmacies within Reading have actually done more hypertension case finding than our local ones here. And that is in areas of higher deprivation. So really reaching our core patients, you know, because they go to the pharmacy not just to get their medication, but also to get the child's CalPol. And I feel like our community pharmacy may know our patients sometimes better than what we do. Our community pharmacy, with my GP hat on, I've received a few calls. This patient has not picked up their medication in a couple of months, you know, just highlighting their concern. Or if this patient has come to pick up, they're looking slightly different, more forgetful, and expressing that concern to their local GP. That is really that sense of community that I feel like is there, could be better, yes. And I feel confident it is on our priority list from a primary care strategy perspective to do better in. Thank you.
Thank you very much. I think all those things we have talked about quite a lot, haven't we, in the last few meetings? But specifically, this is about somebody who is selling nationally. So it's going to be an online service, presumably. So, and, you know, there is a place for that as well, for those of us that, you know, just need to order something and get it delivered because you're at work or whatever. So, I think if everybody's ready to move on this one, it is just to note again this one. I don't think we need to comment, as April has said. We've already commented before on this application, so thank you very much. So moving on to the next item then is the cost of living update. So Sean, are you happy to take this one for us, please?
Yes, very much so, Chair. So actually just picking up on Councillor Stewart's point earlier on, I agree. I think the time has come perhaps to change the name of this report. But just to kind of talk about where we've got to since the last meeting. So clearly, I mean, as the report highlights, some of the economic indicators have improved a bit, but they're just about, if you read the report, the only indicators that have improved. So what we're seeing, and more recently, and Rachel may be able to join in with this, but we had a meeting of this, of the local group made up of the council, voluntary sector and other bodies that are looking at the impact of cost of living on residents. And we're still seeing situations where basically the level of debt is rising and the debt-related issues are rising. And there are some figures in the report from Citizens Advice and other organisations. And we're also, I mean, we talked a lot about the reasons for that. I mean, some of it, I think, is legacy. So clearly, basically, people have been through a very difficult time with rising costs, with, you know, fuel costs over the winter and everything else. But what Citizens Advice are reporting is they're seeing more and more people basically with high levels of indebtedness, and obviously all that goes with that, including the impacts on health. Another observation basically was from West Berkshire Homeless, actually, which I thought was really interesting, was that they are now saying that they're seeing about 70% of the people they're seeing are families as opposed to individuals, which is a very big change since really sort of 2 or 3 years ago. And all of the organisations are by and large seeing an increase in demand. You'll see details there of the demand in from the essential household goods work that have been carried out at the Community Resource Centre. It's really interesting, John, when you were talking about, I thought when you were talking about the issue of housing and housing standards and everything else, we sit in that group, as Rachel will tell you, and many others that have been in that group will tell you, we sit in that group debating how we're going to get people carpets. And that really is the level of debate at some level, basically locally. One of the interesting figures, I think, in this, and I'm not quite sure what it indicates, and we're going to drill down a lot more on the data, is around the Household Support Fund. So you'll see we were given a 6-month allocation to run through to September, end of September. We don't know what the future of that fund is at the moment, and I'm sure we'll get some announcements in due course, one way or another, from the new government. But this time last year, so the fund was approved, the allocations to the fund were approved by individual decision, I think pretty well the day we last met. and that included a range of contributions to the voluntary sector, where the feeling was that the voluntary sector were in a better place to provide for the needs of local residents than the council were by issuing individual grants. But we did keep back a proportion, just over £200,000 for issuing of individual grants to individuals and families in the district. So during the period May-June this year, we have issued 753 of those grants. The equivalent period last year was 150. So there are a few things there. One of them is we need to understand why there has been such a big rise. It could be that there was just that latent demand following winter and everything else. But what that indicates clearly is that that fund is not going to last through to the end of September. So we're looking at basically how we deal with that as an organisation. I did look into, so that this is as well in addition really to a lot of referrals to those voluntary sectors organisations we've already funded for things like white goods and general household support issues. So really just looking at the next steps for us, and the issue of, and it's clear, I think, Rachel, we were talking about this at group, that the issues around health come up all the time in these discussions about debt and cost of living and poverty. And I think one clear step that we need to make is to have a public health input into that group, actually a standing member on that group. So going back to the question of the actions, I think the most significant action we could take is to bring somebody in there with effect from the next meeting. I can see you nodding, Rachel, which is good because we didn't discuss it first. And also, I think at the next meeting, we have talked about inviting the local MPs to the group, basically to have an exchange of thinking with the newly elected MPs. A decision was made that that the group and the chair of the group would write a letter to the relevant minister, setting out areas of concern that we've identified. And also around the future of the Household Support Fund. And because it is clear that now it has become a very critical aspect of local support provision, not just provision directly by the council, but by its partners as well. And there was a debate, I think, really at the group about, I think what we need to do now is to look to, there was a whole debate about housing standards and everything else that we talked about, and everybody was saying that they're seeing lots of issues around housing and damp and mould and everything else, and we will do more to raise the awareness of some of those things. But we're very keen, I think, as a group of organisations, really to define and get to the point what we believe are acceptable living standards for residents, not just housing standards. And I think that is really important. And that includes things like having carpets, not just a roof over your head. So I think really that's the kind of summary of where we've got to. So basically, it seems to be a significant uptick in demand for all of the organisations that they're reporting to us. I think just to say that the issue of cost of living, poverty, debt, whatever you want to call it, has not gone away. And it's sometimes easy to lose that in the headline figures of 2% inflation and things like that. So I think I would very much urge that that we keep this on the agenda, and I still am of the view that given the health implications, the Health and Wellbeing Board is the right place to be airing these matters.
Thank you, Sean. I think I agree that we do need to keep this on the agenda, and yeah, maybe a rename. We talked before that actually cost of living crisis isn't the right word. It's people in poverty. So we have said that before. So, Jeff.
Hello, Chair, and sorry I was late. Unless it's somewhere else in the paper that I haven't spotted. On 4.8, we talk about the contributions of partner organisations during and subsequent to the meeting, which are useful. What we could do with, I feel, certainly Community Resource Centre, Homelessness Project, the trend, we're not getting some comparisons there to show us the growth. if you read bullet point 1, continued high demand. Yeah, okay, but that's subjective in a way. What was it 12 months ago, the demand? And then if you look at the West Berkshire winter homeless, 37 people, 1324 beds. What was it a year ago? How many bed stroke nights? How many people involved? I think that would help us. I think that would help us know the direction of travel. You can say it's getting worse. Welcome back, by the way. You can say it's getting worse, but you've got to put it in terms that, numbers that we can understand. I feel that would help.
Thank you.
Chair, I mean, there is some trend data in there. So if you look at for example, the Community Resource Centre, so they're saying they've seen an 18% year on year. I think that the point you make, though, Leader, is a very good one, and I think perhaps the answer, Rachel, when we come to pick this up with the group, is have a standard pro forma where people can actually provide the information in a format that we require it, rather than basically a narrative which each of the organisations give us, which we seek to interpret. But by and large, what we're saying is that the trend in terms of requests for support is very clearly up, but we do need to demonstrate that and perhaps some of the statistics and some of the data behind that in a bit more detail. I don't know, Chair, whether it's, if you're happy, whether we could ask Rachel, who obviously chairs this meeting, whether there's anything that Rachel would like to add.
Yes, please, Rachel.
Thank you, Chair. Thanks, Sean. No, really, really good summary of what was quite a lengthy minuted meeting. Agree with all the points. I think certainly we've changed it originally, the name from cost of living to cost of living and poverty, but I think people in poverty or poverty forum is definitely the way forward with it. And I guess trends and creating a standard format, Sean, I'm quite happy to work with you on that. I think you just need to be mindful of the capacity of the voluntary sector. You know, they come to this meeting willingly and voluntarily at the moment, and we get good engagement. I think if we ask too much of them, there will be some that will be able to provide that. You know, Newbury Community Resource Centre produce evaluation reports for all of their grants and things already. Kelvin always comes well prepared with data. I think for the smaller ones, if you look at West Berkshire Homeless, they're all volunteers, there's no paid staff there. We may just find that we're not going to get everybody on board with that, but we can certainly, have a go at creating something that creates some data that we can refer back to.
Thank you, Rachel. Nigel.
Yeah, thank you. Just a very quick intervention there, Rachel. My experience with West Berkshire Homeless is that if you ask them, they probably can provide the data, because that's very key to them. I was staggered, to be honest, at the amount of running costs they have. And in my experience dealing with them, they are very good at keeping their data. So definitely ask, I think. And I think you might be surprised at what comes back on that front. Thanks.
I do have, so you're correct. I mean, they do provide actually quite, what I've tried to do is summarise here basically, but in fact behind that, I know, for example, with West Berkshire Homeless, they do have graphs of trends and everything else basically, which they keep and supply. Can I just make one other observation actually, because I did have a kind of note which I'd written sideways and missed it. I do think we need to get back to this issue of housing. As a board, and I mean, it wasn't just the conversations that we have routinely at the cost of living group, the poverty group, but actually it's the topic of it was the topic that we discussed at the recent hot focus group, and I think actually there were some surprises in there for people about some of the issues that are arising with housing. I mean, it's a national issue, but just housing within the district, in what on the face of it is a relatively well-off area, but there are issues out there with poor housing. Can I suggest at some point, basically, I know we can pick it up on the forward plan, but this is an issue that I think I would like to see brought back to this board.
Yeah, I think that's a good idea. I think most people would concur with that. So, John.
Yeah, just 2 points. On the first point, on the public health input, we've done that in Reading over the last year. And so there's a shared experience to be had there about what sort of things might be funded out of the Household Support Fund and other areas. That there is a menu that's been agreed over there now, which includes things like female sanitary products and but also follow-on milk for nursing mothers. There's been an issue of mothers in poverty stealing milk to feed their babies and so on. So there's a package of things that have been agreed to come out of the Household Support Fund over there, and there's one of the public health team is involved over there with this conversation. On the community resource centres, I mean, I'm not as up to speed as I probably should be on what is actually going on in them here in West Berkshire, but something I saw in Israel a long time ago was neighbourhood community resource centres run by the voluntary sector, but in partnership with the local authorities and the health services. And, you know, this might sound strange and obvious, but, you know, being a repository for things like Zimmer frames and crutches and things, which seem to all get thrown away when they're not needed anymore, which seems very odd in the health service doing that, but also providing bulk supplies of frozen meals for elderly people and so on. So actually having a neighbourhood resource centre that is a focal point for this could be integrated into community hubs, you know.
Chair, I very much like the sound of that, Dr. Ashton. I think it's Dr. Ashton, is it? Yeah. We've had relatives pass away in perfectly good, reasonable equipment. Nobody's interested. So we've got a wonderful facility in the community furniture project. You're describing something similar, sir. And I wholeheartedly would support that. And I think we should take an action as a council, Gordon, to you know, keep that on our agenda.
Thank you. April, you wanted to come back. Come to you in a mojo.
Thank you, Chair. Just in support really of some of Sean's comments in terms of the public health involvement. And also it was very clear from our health and housing hot focus session that we need to tackle these. We need multitude of partners, individuals, services coming together to try and tackle issues such as health and housing together. And really that's all about our health in all policies approach to everything we're doing. So just to say thank you to Sean for his report and support some of his comments. Thank you.
Thank you. Jo.
I was just going to pick up on the equipment piece because we do have, and apologies if you mentioned this and I didn't notice it, but we have NRS Healthcare who we already commissioned to do all of this. But I think what we possibly don't do at the moment is advertise that opportunity to people. I certainly see quite a few people on social media saying, I need a wheelchair, I need some crutches, or I've got some, and they don't seem to know quite what to do. Generally, they get pointed towards take it back to the hospital. And of course, that can be something that isn't practical for many people. So yeah, I think we perhaps need to find a way to get more of that information out.
I'll look into this further, but I heard recently somebody was given a sort of almost 3 to 4 months waiting time for an ordinary wheelchair. You know, this we can improve. We can do better.
Rachel.
Thank you, Chair. Yeah, just following on that point, actually, I know that the Newbury Community Resource Centre do have and get donations of wheelchairs and walkers and things like that, as do we at Shop Mobility. So that's one of the services that we actually run for West Berkshire based in Newbury. We hire out short and long-term loan equipment. We often have resale items as well. So we do take donations. So there are places, but I think to echo Councillor Stewart's point, more promotion probably needs to be made of all of these, because we often get asked, you know, I see it on social media, where can I get a wheelchair from, or where can I donate something to? And I often refer to Shop Mobility, obviously, because that's the service that we offer. But people don't seem to know that those things are out there. So raising the profile would, I think, be beneficial for all.
Thank you, Rachel. Yes, I think, you know, we need an information piece on this. We need some publicity.
Yeah, just a quick one. Sean, thanks for the report, really helpful. I was just interested around the social prescribing and whether there's any intelligence coming through in terms of some of these issues manifesting itself in health. I mean, Heike might have a view as well in terms of, are we seeing that connection, people being presented at GPs and that connection into these voluntary sector support organisations to make sure they're getting the support they need?
Thanks, Matt. I mean, Rachel may wish to comment on this as well, but I mean, there is certainly a lot of work done in terms of referrals and things like that that are taking place. I think one of the issues, I think, from my point of view, Matt, and I don't know whether you've got a view on this, Rachel, is that I suspect a lot of the organisations are dealing with the same people. And basically, it's how we pull together packages of support really for individuals. And that includes obviously health support and everything else. And I think, again, with health input onto the group, I mean, this is maybe the direction I think we need to start taking our work in. I mean, the work has been primarily about dealing with immediate financial need and day-to-day issues that residents are facing. But I think actually as we move forward, Matt, the links with health are the bits that we need to really strengthen up.
Thank you. April, I think you wanted to come back.
Just thank you, Chair. Just very quickly, listening to John talking earlier, he's talking about the two bookends of intelligence and communication, and I think this is key into this in terms of we're gathering this intelligence. Intelligence comes in different ways, and some of it is through communication and feedback, and then it's about how we take that intelligence and how we communicate better out to our residents. So I think this is a really good example of saying perhaps we need to communicate better and think about how we kind of do a joint communication package out to our residents.
I think it's very much about how we use intelligence. I mean, in the service that I oversee, the public protection service, I mean, we use the national intelligence model similar to that used by the police. And I suppose in this parlance that we're talking here today, we would use that intelligence to try and put in place preventative actions. In our world, it would be, and then enforcement in our world. But what's really talking about is positive interventions, isn't it, of support. I still think there's always some way to go, isn't there? You know, I mean, if we're not going somewhere, basically, we're not kind of improving. But I think as we go forward, we need to shift the focus, I think, very much in that direction. And Rachel, perhaps this is something we can pick up the next group. I mean, when we meet and maybe start that group meeting actually with some public health input.
Thank you, everybody. Thank you. Sorry. Thank you.
Thank you. And I hope I'm not going too tangential with the statement. You know, when we speak of intelligence and data, and for me, it's also a different form of access. And I wonder whether we've got some responsibility in help improving the digital accessibility for our patients, you know, because we're opening doors, and how to do that safely. Because from prevention to getting appointments, to getting your medications, we spoke of remote pharmacy or pharmacy delivery. All of the extra help is coming from a digital perspective. Every digital conversation talks about digital accessibility and the fairness and lack of access. Is it not our responsibility to also help people and not just write them off? They can't, so they won't. Let's work to help people. Yes, there will be people, some people that can't, but let's not write people off. I really think that is a key thing that we need to do. It touches on so many different areas. Thank you.
Thank you very much, Jo.
Completely agree. And the Mental Health Action Group actually have an action to look at how to talk about digital exclusion and inclusion and work with other partners to try and resolve that problem. So I'm not sure exactly where that piece of work is at the moment, but certainly it is something that's at the very forefront of our minds.
Thank you. Sean, did you want to come back?
Yeah. I agree. And if I go back to the days where this all started and the cost of living home and everything else, we saw a lot of that issue around digital exclusion. I think there is something else here, though, in terms of the way that we work and the organisations that we partner work. Part of the service, as it were, is effectively the provision of the immediate support that people need, whether that's a new washing machine or a carpet. But I think there is the bit that we've never really evaluated in enough detail probably is the value of the conversation. And what we do know anecdotally and from discussions that we've had with people, the ability of people to talk through the issues and challenges they're facing is every bit as valuable as the washing machine.
Yes, thank you very much. Oh, Jessica, sorry.
No, thank you. Yes, Jessica from the Corn Exchange in Newbury. And I just want to thank Sean for saying that, really. We didn't get our update over to Gordon in time, I don't think, but the supper club that was referred to in the actions earlier has launched, and we have had a number of sessions with 3 families attending regularly. There is definitely capacity for more families to attend, so I shall certainly push that back through to you to spread through your networks. But actually what we've found, particularly from the 3 families that have been attending regularly, is that they've found alliance in each other, and that opportunity just to sort of either just step away from their day-to-day challenges or find solace in having that conversation with each other to share their experiences actually has been really valuable, and to be able to have some adult conversation whilst their children are off doing something fun in another part of the building. So wholeheartedly agree that it's really important to be able to provide both that access to basic need, but also that opportunity to feel like you're not alone.
Thank you. Yes, as much as the digital aims that we need to include everybody, it's that face-to-face contact and those human contacts that make a huge difference to people's lives. So I think we've probably been round on this one. We definitely want to keep this one on the agenda. Thank you. So we're moving on to item 14. Ask Jo to tell us about the Better Care Fund. Thank you.
Okay, so I'm presenting this on behalf of Maria. So the report is really for the board to note. So the information that she's provided to me is that the report has been submitted to NHS South East on the 23rd of May with delegated sign-off from the chair, which was yourself, Heather. But we are still waiting for formal sign-off from NHS South East. We've met the targets for falls and discharge to normal place of residence. We met the targets for miss and avoidance in Q1 and Q4, but we do remain in one of the top performing areas across the country. Unfortunately, we haven't met the target for permanent admissions to residential or nursing homes. Our target for this is 205 new admissions or less, and at the end of year outturn we were at 213 admissions, but the majority of these are coming out via the acute trust. So we are working with the acutes to look at the home first model, so we're continuing to push that. What else has she said? And then obviously what we're seeing demand-wise of individuals going into residential or nursing is because of the ageing population, and the individuals that we're working with have higher increased complex needs. But these are being monitored carefully because anybody who we discharge to a nursing or residential home obviously costs us more than discharging them back home. So obviously it's budget pressure, so it is being carefully monitored, and the targets are regularly reported to the local integration board.
Thank you very much. Yes, I did go through this in detail with Maria, and it's a highly complex document that appears to change every year, so that you're not always looking at last year's numbers compared with this. It's very complicated. Helen.
Yeah, thank you for presenting this, Joe. It's very complicated and technical. So I've been working quite closely with Maria and through the Locality Integration Board on the submission of the end of year template and also the refresh of the Better Care Fund plan for 24-25, which, as is alluded to in the document, is a second phase of a 2-year plan. So it was a refresh rather than a redevelopment. We've been looking quite closely at the various metrics, the reasons for variance from those metrics and actions that we might take in the coming year to move towards achievement of the refreshed metrics for 24-25. I just had a question on the point of process as to whether the 24-25 refreshed plan template will also come to the Health and Wellbeing Board. I know it has been signed off by the chair, but just for completeness, I wanted to understand if that will come to a subsequent meeting.
I honestly don't know the answer to that. I would need to check and come back to you. Gordon, do you know?
It is coming to the next meeting. I did try and get the report to come to this meeting, but we just hadn't got it quite done in time. So it's down to come to the next one.
Okay, that's great. Thank you.
Thank you very much. Anybody else, any comments? Then, as this is to note only, we'll move on to the next item, which is again, Joe, the Care Quality Commission Local Authority Assessment.
Okay, so this item is really for information only. So the main messages are we are good. And obviously it's a very new process. We were local authority number 2 out of the local authorities that have been assessed so far. The report has been published online along with the other 2 local authorities who have had their reports published. The process was quite complex, had obviously a lot of involvement, not only from officers within the council, but partnership organisations, service users, carers. There was a lot of corralling going on in the background. So a couple of the highlights are that CQC found that we were good at safeguarding vulnerable people and that our staff were positive and committed. Of particular relevance is that the process assessed the quality of partnerships in the district and that the feedback from partners gave good assurance to CQC that we had good partnership relationships. CQC also spoke to representatives from ICB, the RBH and Berkshire Health Foundation Trust, along with others. And the evidence, as I said, indicates the good partnership relationship. And we are currently in the process of developing an action plan for the improvements that we think that we need to make.
Thank you, Joe. Jeff.
Thank you, Chair. I'm puzzled at, I don't see it very often. Other information not for discussion. That's a red rag to a bull, isn't it, for councillors? I'm not allowed to discuss this. But I don't want to discuss it per se. I want to say well done. I know how difficult these inspections can be. We've got one coming up in the fire service in October and, you know, they're all on edge already. So I just want to repeat my congratulations, my thanks, my appreciation to you and all your staff.
Thank you, Jeff. Joe.
I saw some of the work that was going on, heard about some of the work that was going on. I like to think, and Joe talks about, you know, making sure that we were really ready for this inspection, which I think we were. But a lot of this work that these guys do has been going on for many years. And what I'm pleased about is that this finally gives them some recognition for the amazing work that they do. I'm particularly pleased about the recognising that we're particularly good with vulnerable people and vulnerable residents, because I know that we are, and I know that we work really hard at that. I know care homes are not included in this piece, but, you know, we've had some tough times over the last few years. And a lot of these people are still the same people that care homes aren't included in this inspection, but those same people are delivering across all of those services. So I think it's amazing.
Thank you. I think I just want to echo that. I know, popping in and trying to catch up with Paul during that time was impossible. And the staff I know were all very busily involved in that. So thank you very much, Joe. Right. Again, that was information only and no voting needed on that. The next item 16 is the reports of the various subgroups for the Health and Wellbeing Board, which are also reported through the strategy group. So I'm just going to move on unless anybody has any particular comments on any of those reports, anything that you need to clarify or need to make a comment on. Joe.
I seem to be talking a lot more than I expected to. It was a couple of things. I think these reports are really useful. Again, really good summaries for people of what's going on. And the one in the mental health action group that I mentioned earlier is the piece about digital inclusion and exclusion. It was just really to note the pressures that the Building Communities Together team are currently experiencing. And when we're talking, and when John was talking earlier about this council being a health council or public health council, I think you talked about, actually getting out into our communities, talking to the people that are struggling or that we could perhaps give more information around access to services to give them a better quality of life is so important. And I think that there has been in the past, and I don't think it's in this organisation, I don't think in this council, but in other councils, this sort of aspect has been a little bit, demoted. It's just building communities together, but it is so important. And I hope we manage to get on top of this and get the resources into that team that we need, whether it's within, whether it's paid roles or whether it's within some boosting within the voluntary sector, who I know are already over-commissioned and struggling, but I do think it's really important.
Thank you. Yes. So, any other comments? No. Okay. Thank you very much. Apologies, I didn't see.
No, that's
Sorry.
okay. It was a last minute thought. I found these summaries really helpful, and forgive me if I've missed it, but is there an up-to-date list of the memberships of each of these subcommittees that I just haven't come across yet?
I would have to ask Gordon for one of those. No.
I don't have a list of each group's memberships, but we could probably get that for you if that'd be helpful.
That would be helpful. Thank you.
It might be useful to circulate generally, I think, in that case. Okay, thank you very much, everybody. So the next item I have then is members' questions. Do we have any members' questions?
We haven't received any member questions, Chairman.
Thank you very much. So then I'm going on to item 18, which is the forward plan. And also we're going to talk about the proposal for the next hot focus group as well. So, does anybody have any comments? Jeff?
Chair, you'll be aware that I drew attention to this looking at the forward plan outside of this meeting. There are 17 items, it would seem, if I've got that right. 6 of them for decision, but 3 of those are to approve the BCF quarterly monitoring report. So I'm still trying to get to understand what this body does in terms of decisions, because there aren't many decisions we seem to be making in the forward plan. And I suggest, if you're okay with this, that you, Mr. Pearce, you, Chair, and myself meet and get a little bit more understanding of how we move the dial in this meeting. There's an awful lot of work goes into this. And I see about 3 decisions in the next 12 months. It troubles me.
Jeff, one of the items on the agenda for our next hot focus session is actually what this board does. That is. Okay, we can do that. Does anybody else have any comments around this, the forward plan or anything? John?
No, I mean, I think that's timely, you know, I mean, these boards have been in place now for 10 years. And I think when they were being set up, there was a sense in which there was confusion about what the nature of them was. I took the view that they were a new form of governance of public services relating to health and well-being. I think a lot of people from a local authority background saw them as being in the line of descent from local authority committees, and that they were the creature of local authority as a committee. Whereas I saw them, you know, with the benefit of hindsight and a historical perspective, you know, that one of my colleagues, Mike Eastwood, was trained in environmental health in Liverpool in the 1950s, and he told me that at that time, the public health department in Liverpool had 6,000 staff. There were health visitors, social workers, community nurses, environmental health officers, the abattoir, the laboratory, all these things that had built up over 100 years to be these big empires, because most of the functions of local government had actually grown out of the public health response to the conditions of the slums in the middle of the 19th century. And so you had all these services that were all under the medical officer of health. Now, that all got taken apart in 1974. And then subsequently, we had, you know, the police used to be under the local watch committee and the local authority. They went off to be county level police forces. Fire service, most places, same things happened, used to be under the local government. You had local management of schools. I mean, you know, as a child in Liverpool, Mr. Magnay, who was the director of education, was a force in the land. You know, he was director of education for a city that had 17,000 births a year and a school system to go with it. And they ran all the schools apart from the Catholic schools. But all these things have been taken out. So, you know, so the problem is that you're left with in local government functions that are quite limited. But the functions that need to be mobilized go much wider. And so I thought that the boards of health and well-being were a new governance that was going to bring things back together to be able to have the right voices around the table, to be able to join things up. Now, they've worked out in different ways in different places. And you'll know where you are, I mean, because you're a recent unitary anyway, aren't you? The mirror image problem is represented by the integrated care boards, because the integrated care boards were supposed to be a way of doing what it says on the tin, integrating care. And by the integrated care partnership was supposed to be more of that strategic level, equivalent to the Board of Health and Wellbeing, to join up health service and local authorities and all the rest of it. But the NHS clearly sees them as a creature of the NHS. So here you had potentially two new governance arrangements that were about joining things up, joining the dots, but which there's a tension between the Board of Health and Wellbeing being seen as a creature of local government rather than a joining up body, and the Integrated Care Partnership being seen as a creature of the NHS rather than a joining up body. So that's my analysis.
I may come back, and you won't want a long debate about this, but thank you very much for that. I'm not going to go back to the 50s, but the unitary authority has been going about 26 years now. Right. So we're not actually fledgling. No, but that's not so important. I go back a long way, and I remember post 10 years ago, there was a desire by adult social care here and children and family services to join up, to have people in the room so that they were not as fragmented and fractured. And this body was the way to do that.
Yeah.
But what I don't know enough about it yet, but just looking from a helicopter view, it's spawned a huge architecture around it. This is one body, but if you look at the satellite meetings around it, there are at least a dozen.
Brian
And if
Cox
you're
could probably
putting
describe
all
it.
of that intellectual property, there are 12 officers in this room today. That's a huge expense for the 3 hours. You've got to be achieving something. It's important that we know the issues. It's important that we talk about the issues across the NHS and the local authority. I get it. But we also need to move the dial a bit as well. I'll say no more for now.
Matt.
Helpful observations, actually, and I don't think you're alone in asking the question about the role of the Health and Wellbeing Board and are they delivering what they were set up to deliver. Incidentally, Reading are in exactly the same position and is on my priority list, so I'm happy to have the conversation here as well in terms of how the board's been functioned to date. What can we do to improve it, and what partners do we need? Ultimately, we want to know what's the added value and what's the difference we're making to residents and outcomes, isn't it? That's the end point. And are we making that difference? So I'd welcome that opportunity as somebody new coming to the board again and see where we can get to.
Thank you. And am I correct in saying that you said there's a hot focus session planned around the role of the board? When will that be? I'm sorry, I didn't catch up on the papers.
I don't think we have a date for it. September, October time.
So
we won't do it. Obviously, we're coming up to the summer holidays and things.
Yeah, so it's in the autumn. So that's probably a timely opportunity, isn't it, to pick up some of these conversations? And I think it's important within that we do consider the role of the integrated care partnership, how that's evolving, and the interface between that and the health and wellbeing boards, which I'm sure will be one of the themes that you would want to cover anyway.
Yeah, thank you. Nigel.
Yeah, thank you very much. Could I just voice my personal experience here, because I'm new in the role of portfolio holder for culture, leisure, sport and countryside. I also have something of a sort of quasi-medical background, because when I was working, I was a dentist. But I can say that I find these meetings extremely informative and very, very helpful, because when I'm sitting in a meeting talking about leisure, for example, or culture, libraries, or sporting activities, in the back of my mind, I've got the conversations that we've had here and the health in all policies and the bookend analogy that you had and the intelligence that we get. So I do find it's, and I'm speaking just personally, that it's very informative to sit in a room with everybody and listen to what the various issues are, and that can inform me when I'm sitting in my other meetings. Thanks.
Jeff.
Very quickly, because it looks like I'm disagreeing with my portfolio holder. It does inform, but it needs to do more.
Joe.
It's not always, I agree with Jeff, but I do think because a lot of the issues we're talking about and trying to tackle are massive, it can be very difficult to see the wood for the trees and to see where we've actually made a difference. And I have said in the past, my concern about the subgroups, for example, because I'm part of the mental health action group, I haven't been able to attend that as regularly as I wanted to, and a lot of other attendees dropped off the list. So that is a real struggle to actually get people together to discuss those important issues and achieve something. So I think it would be a good idea to actually review how all of this is working.
So I'll refer you all back to the supplementary agenda, the proposal words for the next hot focus session. And the topic is to improve the effectiveness and operation of the Health and Wellbeing Board. And there are a list of aims there. You know, that's what we're going to be looking at when we have that session. But as we've talked about earlier today, health is important to absolutely everything we do, and the cost of everything that we spend money on comes back to our basic health. So, you know, this is a critical board, but I do understand what Jeff's saying.
Well, I'm grateful to you, Chair, because we talked about this, you and I, and that focus group is going to do the work. I'd like to get Mr. Pearce's view. I think this has been a useful discussion because to a degree, I think we're agreeing. I saw Councillor Marsh nod. So it's appetite to absolutely do this. Thank you.
Thank you then. So we will move ahead with that. And obviously, you know, please come to the hot focus session when it's run. It will be important to have everybody's input on that as to how this group moves forward. So, right, I'm going to move on to future meeting dates. They're on the list. 12th of September, 5th of December, 6th of March and 8th of May. I can't think about May for next year. That's too far away. So I will ask the Zoom host to close the meeting and please stay in your seats until that's done. Thank you. And thank you everybody very much for your input and for attending today. Thank you.